Case 3, firm papule on the finger, and the clinical impression was rule out cyst. And so what's your diagnosis here? Let's look this up. And I always put that thing in about rule out cyst because people always want to call stuff cyst. Because, you know, any sort of nodule in the dermis or subcutis is going to look like a cyst or maybe a lipoma if it's bigger and deeper, you know, and very nondescript. So I've got a whole bunch of different entities, adnexal things and soft tissue tumors and stuff that all were sent in as rule out cyst. So as you guys well know, the only way to really know it's a cyst is either it's got a draining punctum, you know, with keratinaceous debris coming out, or you biopsy it and then we take a look under the microscope to prove it. So, all right. So who wants to try their hand at this spindly thing?
So this is a biopsy of a dermal nodule with some spindle and oval cells, which we were thinking were maybe neural or like a perineurioma because some of the areas look kind of whorled.
Very nice. Excellent. Did any other things come up in your differential?
We also thought maybe like fibroma or giant cell tumor of the tendon sheath, but it's kind of superficial. There's no hemosiderin.
Brilliant.
And it's kind of a weird location for like a pen, and we didn't really see cracks or like a neurofibroma.
Excellent. Very good. So you perfectly recognize that these cells have that kind of thin, stretched out spindle look with a little bit of kind of buckling or folding or curving of the nuclei that gives you that feel of a neural lesion. But you also recognize appropriately that there is a lot of whirling and swirling in here, both in these kind of sclerotic collagen-rich areas. I mean, if you saw a lot of this, you could think a little bit of like a plywood fibroma, sclerotic fibroma, if the whole thing looked like that. But here there's kind of some more cellular areas also. And as you rightly recognize, there is a whirling and swirling and wrapping kind of growth pattern. And when you see that, you should think of perineurioma, or at least a tumor with perineurial component to it. Let's see up here. I think the whirling is even better up here, somewhere in here. And so, yes, so this tumor, I will show you the stains. And oh yes, I also, before I go on it, make sure I got this all for the recording. Your other thoughts when I pressed you for it, you nailed the diagnosis right away. But when pressed for additional diagnosis, you said you could think a little about, could it be some other spindle cell lesion that could occur on the hands and feet, like a fibroma of tendon sheath or a giant cell tumor. But you perfectly recognize it. Those are usually deep down on the tendon sheath. It's very uncommon to see either of those entities up in the skin, and of course also the morphology is not great for those. And palisated encapsulated neuroma is an interesting thought. You're right, it's not quite as fascicular and not quite as, it doesn't have nice cracks, but those can occasionally occur on acral skin. It's an uncommon site, but when I see them, you know, the most common site obviously is like the nose or the cheek, the face. But when I see palisated encapsulated neuromas at a non-facial site, it's almost always the hands, actually. So, so it's kind of interesting that you can sometimes see them in that location. But here's more of that whirling and swirling and kind of wrapping growth. Sometimes it'll be wrapping around like a small vessel in the middle. And many of the cells look spindle, but some of them look a little bit more round to ovoid. And that's common in perineurial cells. The perineurial cells are kind of like, I think of them as kind of like an oval-shaped plate, that if you have them turned one way and look at them on end, they look like a thin spindle cell. But if you flip them 90 degrees, so that just like if you're looking at the plate holding it in front of you, you know, then it looks like more of an oval shape. And I think that perineurial cells have a shape kind of like that. And that's why, depending on the angle of cut, they either look really thin and spindled, or they look more like kind of oval to round. All right, so let's look at the stains here. I did not give you guys these stains. Oh. So this is CD34, and it's good to remember that CD34 here is the control tissue. And look, what's this? This is a big slab of dermatofibrosarcoma protuberans, right? Diffusely positive for CD34, fat entrapment with that honeycomb pattern, right? And I've got other videos about DFSP. I'll put links down below if you're watching at home. And so that's just control tissue here, okay? But just to give you an idea of, that's what CD34 looks like. But look at this. Before we go look at the other thing, look at DFSP. Because of its storyform pattern, it actually has quite a bit of whirling and swirling growth. And let's look at the perineurioma here. It's got a very similar staining pattern with CD34 as we saw in the DFSP. So the one take home that I want you to remember here is that perineurioma should be in your differential for DFSP and vice versa, because they both can have similar cytology. They both have a kind of swirled appearance. And one of the big differences, if you see a lot of fat trapping, that would point you towards DFSP. But if you've got any doubt, you can do molecular to test for collagen 1A1 PDGF beta rearrangement, or the newly described PDGF-D delta rearrangements that are seen in DFSP and are not positive in perineurioma. But just remember that CD34 is very sensitive for DFSP, but it also stains lots of other spindly things, including many cases of perineurioma. Look at how whirled and swirled that is. Isn't that amazing? If you don't like that, I don't know how to make you happy. I mean, that's it's like some modern art right there or something. So in any case, and also neurofibromas, which can have some perineurial component and swirl and whirl, and you can have hybrid tumors that are perineuriomas with neurofibroma or schwannoma. So recognize that you can see CD34 in the majority of neurofibromas actually will be positive. So those are pitfalls that those sometimes can get overdiagnosed as DFSP. And here, though, we have, in addition to this CD34 positivity, here's the epithelial membrane antigen, EMA, and let's look at our control. It's always a good habit to, when you have a immunostain, I try to always look at the control first, just as a habit, because it's easy to get focused on looking at the tissue and to forget to go check the control. And stains are really amazing, but every once in a while they fail. Something goes wrong, the reagent didn't get to that part of the slide, whatever. And then you need to stop and, before you actually interpret the stain as being negative when maybe the control failed. So here's an example of a sebaceous lesion with really strong staining for EMA. And of course, you also can check the internal control on your slides. Look for structures in the patient tissue that are supposed to be positive. That's actually better than the other control tissue. The internal control on your sample is actually the very best control, because it's the tissue that's in the exact same environment and has been processed the same way, etc., as the actual tumor or lesional tissue. So here you can see there's some EMA staining in the epidermis, in the sweat ducts, and also look, what's this little guy? It's a nerve, and it's staining the perineurium around a normal nerve. And I wish I could zoom in closer, but these are little tiny nerves in the dermis here, and they've got a little ring of perineurial cells around them, the normal perineurium, and that highlights with EMA. And so this tumor, which is composed of perineurial cells, the perineurioma, is also positive for EMA. Now, this one worked really quite well. In real life, I find EMA to be a tricky stain to use when dealing with spindle cell lesions. I've seen things that look great for perineurioma and even stained with other perineurial markers, but had very weak or very little EMA. And I think it has something to do with the technical details of how the EMA is performed. Actually, I've heard some other people say that they've gotten it to work in their lab by manipulating the antigen retrieval times and stuff that's beyond what I normally actually deal with in my part of the lab. But in any case, just know that EMA is a tricky stain, and if you're watching at home and you have trouble getting EMA to work, I do too. This is not my usual. This is like a really good one that worked really well. And then the other thing is that because of EMA not being a perfect marker, there are two other stains you can use for perineuriomas, and those are GLUT1 and Claudin-1. And both GLUT and Claudin will highlight these elongated little thin streamers of cytoplasm that stretch out at both ends of the spindled cells. And I wish I would have got this scanned at a higher power. This is from quite some time ago. But here's one you can see. See, there's a little spindle cell, and look how long its tail is. It goes way, way, way out there on both sides. And the idea is that perineurial cells, their normal function is to wrap around the nerve, right, and form the perineurium, kind of the way meningothelial cells wrap around and form the meninges around the central nervous system. Perineurial cells are kind of like the peripheral nervous system, a homologue of meningothelial cells in the CNS. And so they have these long processes that are meant to wrap, and that's why they make the swirling growth, and that's why they have these long, thin tails. And so again, you can stain them with EMA, GLUT1, and Claudin. And then if we were thinking about, well, could this be a hybrid tumor, you could do then a neural marker like a SOX10 or an S100, and they should be negative in a pure perineurioma. And if you've got areas that are S100 and SOX positive, and then other areas have a lot of EMA or one of those other perineurial markers, then you could either, depending on your viewpoint, you could either call it a neurofibroma that's got abundant perineurial cells, or you could say it's a hybrid benign nerve sheath tumor with perineurioma. Benign either way, whichever name you like to use. And I've got some other videos about neurofibromas and neural tumors. So this is one of the things to keep on your list when you're thinking of DFSP. Keep perineurioma in mind. When you're thinking of a nerve sheath tumor, but S100 and SOX10 are negative, think about perineurioma, especially if there's whirling and swirling kind of pattern of growth. And there's a nice example of that whirling kind of wrapping type of growth. It's quite pretty. I really like these, and these are benign tumors that don't need any special treatment. Simple excision is curative typically. So it's a good tumor to know about because it can get confused potentially with DFSP. All right, any questions? Great. That was a 34. Oh, yeah, I will show you the one other example here. And that one the one I just showed you had some areas of sclerosis, and there is a variant of perineurioma called a sclerosing perineurioma, and it tends to occur on the acral scan on the hands or feet or digits. And this one is kind of sclerosing, but it's not quite as much so as like the true sclerosing perineurioma. And it doesn't matter. It's just a morphologic variant for pathologists to recognize. There's no difference clinically to my knowledge. But while we're here, I do have one of those pulled up. And here's a nodule. This was a little deeper down. You can tell it's been shelled out because there's no connection to the dermis. It was probably down in the subcutis or near the tendon sheath on the digit, if I recall. And this is much more sclerotic, right? It's like completely hyalinized. And instead of those long, thin, stretched out cells that I just showed you in that perineurioma, sclerosing perineuriomas tend to have a more rounded or oval cells, and they almost make like these little chains or cords in this really sclerotic background. So a very different kind of look. So that's why I wanted to bring this up, because it's another perineurioma. It'll stain similarly to the other one, the conventional type that I just showed you, but otherwise has quite a different appearance that might confuse you at first, because you'd be like, that doesn't look anything like the perineurioma I've seen. And there are some other unusual variations as well. So it's kind of a curious and relatively rare soft tissue tumor that's benign and beautiful. My favorite combination.